So to further our perspective on international perspective on patient feedback and how we can apply some of the learnings in our Australian health and aged care system, and we do have some aged care providers logged in today listening to this presentations, I'd like us to welcome two people that I regard as colleagues and friends, and I miss them catching up with them. One of them is Professor Jason Leach, who's the National Clinical Director of Healthcare and Quality Improvement in the Scottish Government. And Jason is, well, I hear they call him Mr. COVID in Scotland because, and that's James on screen. We haven't got Jason on screen yet, but Jason's Mr. COVID because he's the voice piece of the public health approach in Scotland. So hopefully he'll be joining us soon. And we've also got, and I'm really pleased, we've also got Dr. James Munro, who's on screen there now. And James is one of the Care Opinion founders and also now Chief Exec of Care Opinion UK. So both James and Jason have in-depth insight into the National Health Service, the NHS, and the key role the patient voice plays in improving the healthcare system in Britain. They have seen how public online feedback can contribute to quality improvement right across the entire healthcare system and how this compares and works in partnership with traditional feedback mechanisms. So today, Jason and James will delve further into the conference topic, which is about the purpose of patient feedback. Why do we do it? And how does public online feedback address the missing link? So I'm just still waiting for Jason to come into the forum. We know he's there. We're just waiting for him to enter the screen.
You're looking anxious, Michael.
No, you know, I can tell a story, James. So, you know, it's a problem.
You'll have to do your cricket rain commentary.
Oh, hi, Jason. Very good morning to you, sir. How are you?
Good morning to you. It's a little bit early, but that's not entirely why I was late there. That was a technical glitch.
Yeah, I know, mate. I know. I get that. And thank you so much, Jason. I've been, you probably could hear me. You could probably hear me even in Scotland from Australia. Sometimes I've been told with my voice. But look, a very warm welcome and thanks to you both for joining us. And as I mentioned to you previously, it's really going to be a panel discussion with the two of you, and because I know you've got lots to say, so I'm pretty much going to be quiet. But I've just got maybe just to kick it off with James, a question, if that's okay, James. So you and Paul Hodgkin founded Patient Opinion, now Care Opinion, back in 2005. And I think you have about 90% of hospital trust in England engaged in some way, and both Scotland and Northern Ireland health systems have now come on board. And this is a big question, but I'm sure you'll answer it in certain ways. What key learnings or advice can you share with this Australian healthcare audience that we've got online here around consumer engagement, and more specifically in regards to doing it in a public domain? That's different.
Yeah, it is different. It is different. And listening to the panel this morning, I thought there was, an enormous amount of wisdom already there with the experiences that people have had using public online feedback already in Australia. I think for us, what drives us is trying to think about this not just from the perspective of organisations and staff, but actually primarily, first of all, from the perspective of citizens. So I think that's something that doesn't always come naturally to health service staff, clinicians, and so on. They used to think about patients, but think about citizens, thinking about people who need to share their experience, who want to help the health service, who feel that something went well or something went badly, and they want to make a difference. So starting from that perspective leads you, I think, to create a different kind of system from the things we've been used to. obviously, we're all familiar with the traditional forms of feedback in health services here in the UK. We have, annual patient surveys at national and often at local level. We have something in England called the Friends and Family Test, which is a kind of a net promoter score. Would you recommend kind of a thing? We have complaint systems and so on. These are not always it often seems to me that these are designed with the organization in mind or with policy in mind, but not necessarily something that directly serves the citizen in a patient-centered, person-centered way. And I think that's what we're learning, I think, and it's been a bit of a surprise to us, perhaps as well as to everybody else, is that it is possible to build something which patients and families really like as a form of feedback and really value, because they feel equal and respected and able to engage in a way that's not onerous or threatening. And yet staff really like it too. And I think that's been the surprise, that it is possible to build something that everybody can get something out of. So it's not just serving a sort of, feeding the beast of organizational data systems. It is actually serving a wider public purpose. So that's the thing that we're, that we like, and that guides us in continuing the journey, really.
I'll come back to that, James, around the purpose of feedback, because I think you just touched on it then. But I want to just check in with Jason here. Jason, you were described once, and I don't know the exact words, but something like care opinion is the single most important thing in the past 10 years that the Scottish Government has done for the public health system. What would you say that? That's a big statement. Yeah.
It's almost right, Michael. While let the truth stand in the way of a good story, it's almost there. I did say something very similar. What I said was it's the most important thing we've ever done for person-centered care, and I think that's true. I genuinely think, and I would defend it today. We've done loads in this country, much of which is nothing to do with me or the government or anywhere else. So one of the things we've tried to do is tackle person-centered care from the very granular side of open visiting across all of our systems. So apart from this horrid pathogen we're dealing with, which has unfortunately had to roll back some of that. When we get back to the next normal, we'll have open visiting again. We've done that list that James just gave of having a compassionate complaint system. All of those, we got all that. But it still doesn't feel close to the user, does it? It still doesn't feel as though there's an actual way of linking staff, system, and patients and families. And that's what this has done. We did it. The thing about Scotland, and James will tell you this, is that any organisation that wants into Scotland finds it enormously frustrating to get in. But once you're in, you get the whole country. So we're very selective in who we choose. Yeah. We like to be sure that this is really going to help, because we've got a very integrated health system with quite a lot of command and control. So if we say yes to something like care opinion, that's a big deal for us, because that's going to go from Stornoway in the islands to Edinburgh. And that's what we did. So we ran some prototypes. We tried it in one of our health boards, who got very enthusiastic for it. In fact, they put pictures on the back of buses. And they absolutely loved it. And I went to see it and got to know James, understood it. There was a Scottish version of the organisation, so Scottish leadership locally that was really important to us, people who could do the local training, who people could get to know, because just like care opinion itself, the organisation is relational. So we had to know people who we could speak to when it wasn't working, or we needed to train new groups of dentists or whatever we wanted to do. And then we went the whole country. And I think at that point, it genuinely did become the most important thing we'd done. It doesn't work in a week. James would make no claim that it works. It works immediately. It takes a while for people to understand they're not going to get in trouble. They're not going to break any rules if they answer Auntie Mary, who's written in about our COVID vaccine. They can just answer, and good things will happen. And I think that's been proven now. I don't know how many years we've had it. must be 6 or 7, maybe
It's
longer.
about 7 or 8,
James will know.
it's about,
Yeah.
it's about
Hey, you've
7 years at least.
You've done great work, Jay. And look, Jason, on your work with COVID, I won't go into detail, but you've just, I mean, we're hearing, you know, you're plastered over here as well as some, especially COVID in Scotland. So, and I can imagine that, you know, that's a lot of work you're doing there. You mentioned the word relational. It's something that really resonates with me. Can you tell me what you mean by that? Like when you say care opinion is relational, what were you thinking there, Jason?
So I think it goes beyond the technical. I think it's important not to suggest that it's only relational. I mean, it needs to work.
Yeah.
So if the digital solution lets you down, nobody's going to do it. If the posters aren't up and the postcards aren't in the appointment letters or whatever system you want to use, if that has to be excellent. The graphics have to be good. The system has to be reliable. The phone number you phone to tell somebody you need training has to work. But at its core, I think what James and his colleague invented was a way of creating relationship between a provider, whatever that provider is. It might be a social care home, it might be a dental surgery, it might be a GP practice, with a user. I don't really like that word, but the patients, the families and the carers who we serve. And we've all got those relationships. Some of them are more anonymous than others. So it can, a radiology service can be quite anonymous. So going for your CT scan, perhaps for the only time in your life, can be a very, very anonymous experience. And you might be there for 2 hours. You might never know anybody's name. You might have a horrible experience, or you might have a joyous experience. And what James has created is a way for you to tell that system which one of those you had. It might then be a relationship you've had for 30 years. It might be your general practitioner. It might be your optician or your dentist. And that's a long-standing relationship. And you want to either celebrate that relationship in some way, or you want to suggest that, well, maybe that Tuesday morning, Frank wasn't at his best. And I would like to let Frank and the team know that maybe he could have done something a little bit different or whatever. And I think this has created that it's not perfect. It doesn't deal with every single transaction in the Scottish Health Service, but it gives us enough information to be able to make change.
Yeah. Thanks, Jason. Yeah, James.
Can I pick up on that, because I think what Jason's saying is absolutely right. That I think what we're learning actually is that pretty much all feedback is relational, even when you try as hard as you can to get rid of relationships. So often, you know, with surveys, for example, people are constantly, you know, they're trying to design an instrument which is uninfluenced by emotion and relationships. Just give us your data, you know, tell us how you felt about this or that. Here's a scale. You know, it's as bland as we can possibly make it. And yet, from the patient's perspective, and indeed also from the staff perspective, this is still entirely relational. We have lots of evidence pointing us in this direction now. For example, we're doing a series of research chats here at Care Opinion every month, which are online and they're recorded, so you can watch those back if you want to. And the next one, we're talking to a prof in Florida who's talking about his research on surveys where people put perfect ratings for their clinicians, 5 out of 5, 10 out of 10, and yet negative comments. And why do they do that? Why would people do that? It's because they don't want their clinicians to get into trouble, but they do want them to improve. You know, they do want to tell them something. There was something they could have done better. So people are sophisticated about their feedback, whether it's through Care Opinion or whether it's through a complaint system or whether it's through a survey. There's always a relationship involved. And what's fascinating also is it's highly relational for staff too. And I think that's one of the reasons why Care Opinion works for staff in the way that sometimes survey data or quantitative data doesn't seem to work as well in provoking change. It's because people do react. They react as humans. They react emotionally. They think, this person's had a bad time. I want to help this person. I don't want that to happen again for people like the person who's told their story. We need to make a change. So it's that human connection that's mediated through the stories that appear on Care Opinion that I think often motivates people to produce change in ways they're not always motivated by a pie chart or a bar chart. Sometimes people are. Of course, that's not to say you don't need quantitative data. Of course you do. You need it to tell you whether you've done it right. But often it doesn't inspire you about what to do. So you need it for comparisons, but sometimes it's not the thing that tells you how and what needs to change. So I think this whole question about relationships and a relational feedback that connects people in a way, is really important. Actually, I think we can go further with it. We want to go further with it. It's all about time and resources, of course, and we're still on the learning curve. Well, for example, one thing we'd like to do is build, and we're starting to do this in a small way with academic partners, but we want to make it possible, for example, for healthcare providers to invite people who've told stories about a particular service to then come in and get involved in quality improvement work, for example. So it becomes not just a feedback platform, but a kind of dating platform for people who want to improve healthcare. It becomes a way of connecting people together, whilst all the time allowing those people who don't want to do that to sit it out, which is fine. So it's still about protecting people's identity and autonomy, but also giving people the chance to say, well, I've given my feedback, what can I do now?
Yeah.
Can I do more? Because lots of the people on Care Opinion are there because they want to help.
So but they can engage at different levels as we know. Yeah.
We're starting that in the research arena. So we've already done some projects. We're working with the Patient Safety Research Centre in Yorkshire and Humber, and we've already run a few or used Care Opinion to find participants in research projects for a number of researchers, and that's going pretty well. So that's our kind of test bed for this idea.
Yeah. Jason, there's a question here. Any tips, and James, for you as well, it just says to Jason and James, any tips or advice to help build the capacity of staff to respond to stories? We heard earlier in Australia, we had a CEO in the panel from Victoria, and he said he used to do all the responding, but now he doesn't do hardly any of the responding. He just lets it go. He would like to review them, but he thinks he's done enough to trust his staff to respond. Jason, any views on that at all around?
I think you have to do it gradually. I think it's very, very easy to come on and say, yeah, just let everybody do it. That's a massive change to how we've conventionally done complaints or feedback. So I don't think you can do that in one jump. I think you have to do it gradually, and the organisation can help you with the training and how to do that. In Scotland, what we did was we let people choose how to do it with a lot of advice. And initially it was the feedback coordinator or the chief nurse, or of course conventional. We want to, don't you reply from that ward. We want to check your reply before you do so. Yes. And people then get over that. And I started to reply. We kind of, what would you say? We socialized it quite a lot across the country. We got, I remember the day the Scottish leader of the organisation stood in the Parliament and signed up all our members of Parliament. So as they were walking past the table, we got every member of the Scottish Parliament to sign up. And they then got an email every time there was a story in their area. And that began to, that was scary for me, because I got a lot of the, why are they saying this about my hospital? Or why are they, what is this? But they also, it turned out, got the good news. And politicians don't often get the good news. People don't queue up to see their politicians to say how wonderful things are. They only queue up to see their politicians to say how terrible things are. So we started to really socialize it a lot. So I would go, my only role was to kind of communicate it to the executive leaders in the organizations and talk to them about using it wisely, opening up. And then some, like your chief executive you just described, some of the more courageous chief executives went first, and they started to release it into the units. And now we still have some people who think it's a little bit too open and free, and then we have others who don't care, who just let it go. And I think that's probably the best way to do it. But if you're starting, I wouldn't do all of that in one jump, tempting though it is.
Yeah, no, and
No, I
it's
think
what's happened here too. Sorry, James.
No, I mean, I think that's right. I mean, it is a gradual process. People need to build the skills and the confidence to do it. I mean, some people just have the skills right off the bat. You know, you have people who are just very natural online, are compassionate, thoughtful. You have other people who find it a bit of a shock. You know, often people's first response can be quite a scary business, but people get the hang of it very quickly. And, you know, Becky, who was on just before us, was talking about her study of introducing care opinion at the Royal Cornwall Hospitals Trust, who now have, I think it's, 300 responders or something across the trust. And they built that up, at a fair old pace, actually, but they using a very simple kind of approach to training teams, giving them a certificate. It took about half an hour to go to a training session, get your certificate, and then off you go. And once people get the hang of it, they do like it. So I think it's just something exactly as Jason says, you have to start with your enthusiasts, start with your people who are good at it, let them show how to do it, set the tone, and then keep going. I mean, we've got Notts Healthcare here in the UK that's been using Care Opinion now for over 10 years. And actually they have approaching 1,000 staff now on board, and they train people and tell them about Care Opinion as part of staff induction. Now it's just built in because it's kind of, part of the organizational lifeblood now. Yeah. So they just make sure that all new staff joining the organization know about Care Opinion and understand what it's for.
What you're describing there, both James and Jason, is this continuum or journey of using public online feedback. It's gradual, and that gradual bit about who gets to read the stories, who's email alert or email alerted, who can respond, how many staff are listening. So it's a gradual sort of cultural adoption around transparency, I guess, and it's why Western Australia here first came on board. It was initially a political decision because they wanted to build transparency in the health system. And we often hear that word bandied around. Well, we do here in Australia, more transparency, but what does it really mean? And Care Opinion demonstrates that quite clearly. Your point, Jason, about the politicians, we do have, fortunately, some politicians in Australia that receive the stories, and we know they're reading them because, as you know, you can tell who's reading the stories in the staff activity icon on the side of each story. So it's always encouraging to see that. I've got a question here to both of you. Why would a service respond to a story publicly when the matter is already being dealt through an internal process?
Well, I mean, that can be tricky. I mean, the point is that, of course, as I think we've already talked about in earlier sessions, most of the feedback's positive in any case. Only a very small proportion of people will already be engaged in a formal process like a complaints process. And we've often had debates within Care Opinion about whether feedback about the complaints process itself is a legitimate sort of topic for Care Opinion. We think it is, because people's experiences of complaints processes can also be improved, just like their experiences of healthcare. And often the experience of a complaints process can be poor. We know in the UK context that a lot of the complaints that are seen in the NHS complaint system are about the complaint system. So, there's definitely room for improvement there. But an organisation, I can understand why organisations might feel, look, we're dealing with this as a complaint, why do we have to deal with it in public as well? But, that is an opportunity to demonstrate the change that's being made. We know that often complaints don't lead to improvements. They don't lead to learning. They may get responded to. That doesn't mean they've created any kind of wider change or improvement. And, you need to show complainants that their complaints were worthwhile, that they're actually making a difference. So that's an opportunity to do that. Sorry, Jason, go on.
No, I was going to say a very, very similar thing. I was going to also give permission to stop. So my public-facing role in COVID has caused me to learn a little bit about society that I kind of wish I hadn't. At one end, there is joy and mostly over 75s, frankly, who love me, which is great. I'm very comfortable in that space. They send me lovely letters and stop me in the street. But there is an edge to society that isn't quite so pleasant, and Care Opinion gets that, just like everybody else gets that. Social media gets that. So you don't remove your judgment before you reply to people. You should, of course, be polite and kind and reply. But if you get abused or if you get asked the same question for the 47th time, you are allowed to disengage. That's okay. Care Opinion won't come round to the house and shout at you. So do your absolute best to engage, even if it is a complaint that people feel hasn't been well handled, which may be a completely legitimate concern. And you are allowing other people to learn from experience in there as well, both in your reply and how you change and how you deal with it. But it's not all one-sided. You can, if you need to, disengage from that process if it reaches that point. Now that's very unusual. James will know how much they try and stop any edgy ones, or if there's strong repetition and somebody's just not accepting what's being said, then that would be paused. So I think Care Opinion is actually one of the places you can do that relatively safely. It's much easier than in social media, where it can just keep coming and coming and coming.
That's right, Jay. And we do pause. We get stories like that, and every story has to come through the gatekeeper, so to speak. That's us. And if we can see someone, that the health services generally try to address the issue, but they keep coming back, then we will let that. We may not publish further. We will let that storyteller know, hey, look, we think this has been dealt with. You might need to try other avenues because our platform doesn't quite suit what you're wanting there. So there is a stop button, and I think that's what some of the providers have liked about us, that as you said, it's not a social media platform in the sense that everything gets put up there and it can keep going. So that's certainly something that we found here in Australia. I'm not sure if you're, Jason, we've got lots of people from Australia. They're firing in questions left, right and centre here to both you. And look, we've said that we will gather these questions and we will, in our post-event communications, get responses. So we'll come back to you on some of those for sure. So I'm just looking at another question here. So this is come up on the priority. Social media is used by millions of people across the globe. What is different about Care Opinion?
Partly exactly what you've just said. The moderation is important, but also I think the separation from your normal social media account. So you may have a Facebook account or a Twitter account, or you're on Instagram or something. That's not necessarily the place where you're going to start to open up about your cancer, your miscarriage, your continence issues, your depression, your anxiety. You want some anonymity for that. You may not want all your friends and family who follow you on social media platforms to know about those issues that you're having. So Care Opinion is in a sense a safer space for that, because you don't use your real name. It's not connected. It's precisely not connected to your social media accounts. So it's not shared widely. So you can say what you need to. It also connects you directly with health system providers in a way that social media can often be quite ephemeral. Things come and they go. Tweets appear and disappear. There's no guarantee or expectation necessarily that a healthcare provider is going to respond to you in a tweet to help resolve your issue. So that's also part of it. And then another thing is a deliberate decision we made actually with Care Opinion, which is we don't allow public commentary on stories on the platform. And that's because there are many conditions which are stigmatized, where people have judgments, people jump to all kinds of judgments. The classic example would be somebody attending an emergency department with an injury due to deliberate self-harm, for example. Now, if you posted that on Facebook, you would immediately get 100 people telling you that you're wasting health service time and you should probably go and jump off a bridge. and that's not going to be helpful to people. That we don't want that. We want people to be able to share those stories of vulnerability and suffering and sometimes self-harming behaviors or whatever it might be, in a way where there's not going to be a social media pile-on, and there isn't an opportunity to judge them. So for all those reasons, and for the purpose of aggregating and demonstrating health service involvement and health service improvements, and the fact that people are listening and being able to show that easily, and to make it safe for staff to respond without then staff responses being judged by all and sundry, I think these are all good reasons why this can't be done through an open social media platform in an unmoderated way. Thanks,
James. Any comment there, Jason?
James has covered it very, very well. I was going to say safety on both sides of the relationship is how I was going to summarise it. Particularly for staff, I think. So James covered a lot about the user, the patient and the family. But I think staff find it a safer space to use. It's professional. It's going to be moderated. If somebody decides to have a go at you, then that's going to be dealt with professionally. And you're doing it within a professional setup, both in your workplace, because your workplace has decided to sign up to Care Opinion, and Care Opinion itself is a professional organisation. So it feels to me the right place to do this type of feedback. It is more raw than the complaint letter, the long 3-month response time, and all of the things we're used to. So it does feel pretty quick and new. So it's got some of the advantages of that social media world, but it feels much more appropriately managed. Is the wrong word, because managed makes it sound as though it's all controlled.
Yeah,
and it isn't as controlled as that suggests. But it's made safe to allow you to do that in both directions. So you certainly wouldn't want to use my social media for complaining. You just need 5 minutes in my social media and you'd run a mile. So.
I think that's right. I mean, we think of it in terms of both structure. We're structuring a conversation for benefit. So we're trying to create a structure which produces a good outcome for everybody involved, if you like. So that's part of it. It's structuring for a sort of positive resolution, if you like. But it's also a kind of slowness. So exactly as you said, Jason, it's fast, but it's not that fast. I mean, and that's deliberate. We don't want immediate gut reactions. Why are you saying that about our service? That's wrong. We want to slow the thing down a bit of time for reflection, a bit of time for getting over that immediate kind of reaction. Oh, actually, they've got a point. What are we going to do about this? Let's post a response. So there's, as you say, a lot faster than the things we're used to doing, but a lot slower than, jumping onto Twitter and shouting at people.
One of the things that you said before, there's one particular hospital trust that's nearly got 1,000 staff responding. A priority question that's come through is, how do you encourage healthcare staff to be more engaged in patient experience? Because the attitude is, well, that's the patient experience department. My job is to get on, with helping patients or managing the staff. Patient experience sits over there. So how do you encourage staff to, where patient experience is everybody's business? And I guess by patient experience, I mean, if patients are before you, clinicians would say, I am engaging with the patient's experience. I'm fixing their experience of illness. But in terms of patient experience about the feedback component, how do you engage, increase sort of the staff engagement around that? In Australia, I think that's a bit of an issue. I think we have specialised patient sort of feedback, and that's not a criticism. I just think that it's just our history. That's what we've done, and I suspect it happened in Scotland and England as well. I would imagine that's pretty much the same. But it sounds like when you said you had a hospital with 1,000 responders, to me that's enormous. I mean, I don't think that ever happened here. I hope it does. I think it's
yes. Well, I mean, it took them a while to get there. Like we were saying, it doesn't happen overnight. I mean, I think that clinicians do care, exactly as you say, very much about the experiences of patients.
Yeah.
What they might care less about is the sort of organizational structures that are put in place to, if you like, monitor, manage, improve what we like to call patient experience, with capital P, capital E, that sort of, I think in a sense, we have corporatized it a bit in a way that means that clinicians can say, well, that's someone else's job to do that. That's not what I do. I do the clinical bit, somebody else does the patient experience bit. That doesn't mean that clinicians no longer care about the experiences that people are actually having. It's just that they may not care about the organizational mechanisms so much.
Yeah.
So that's part of it. But having said that, there is definitely, there is research showing that clinicians, doctors specifically, are quite ambivalent about patient feedback. They really have mixed feelings about it. In the sense that they'll say, well, it's really important that we listen to what patients are saying, and patients can tell us how we're doing things well or badly. But at the same time, they don't always know what they're talking about, and sometimes they give us feedback because they're trying to sort of jump the queue, or they're trying to sort of cause trouble or whatever it might be. So there's a paper by Joe Farrington and others around this ambivalence, and this ambivalence isn't just to online feedback or narrative feedback, it's also to survey feedback. So that ambivalence exists however you do the feedback. And so I think there is a sort of, medical and nursing cultures over the last 200 years have not necessarily prioritized this idea of feedback and learning. It's not, and that's not going to change quickly. That's not built in, it's not built into professional DNA to sit down with patients and say, how did I do? What could we do better? That hasn't been part of professional cultures traditionally. It may, some clinicians may always have done that, but most won't have. And so it is a gradual cultural shift. It's not just an individual shift. It's a cultural shift we need to see, so that people just take it for granted that, of course, we ask people what their experiences are like. And of course, we use that to improve our service. That's important. But we're not there yet.
No. I think we're on the journey, though. Jason, one of the we were in Patient Experience Week here. I don't know if it's global, but it's certainly in Australia, it's Patient Experience Week. And New South Wales, who I know you know well, have just released a document called Elevating the Human Experience. So I like that term, elevating the human experience. I think it invites everybody to elevate the human experience across health services. So any comments about that? I think it's wonderful.
I think it's a good slogan, isn't it? It's a good way of thinking about it, and it goes to the core of what James said in the answer to his previous question, that what we're trying to do here is we're trying to get beyond the culture of people are just going to criticize me, or there's no time, or all those other things. And trusted voices like James and I can't convince the 1,000 people to do feedback, I'm afraid. So those 1,000 in that health organization that James is talking about aren't doing it because James told them to do it, much as it's a disappointment to them. So it may be that James persuaded the first 6, though, or the first 10, but the peer group has to persuade the next peer group. But there has to be value.
Yes.
So something has to have changed or been better or not worse. Part of that culture is because traditionally complaints are really difficult for clinicians. They're hard. You feel unrespected. You feel hard hit by whatever it is that's said, and you don't feel as though you get a fair shout at responding in a meaningful way. You suddenly jump from 0 to suddenly I'm in a tribunal or whatever it might be. And to strip all that away to get down to the fact, no, this was just a lady who waited too long in your waiting room, or couldn't read your public information because the letters were too small, or whatever it might be, not to diminish the feedback in any way. But then if you engage in that, you can then make changes that make it better for those you care for, your other patients and families. And that, I think, is how you get to 1,000. It's that old diffusion curve that we talk about in quality improvement all the time, that my job is not to persuade the whole curve. Michael Greco's job is not to persuade the whole curve. Your job is to persuade the first set of people to take a risk and go for it. And then they will gradually persuade the rest of the curve. And at the same time, I think there's something about us persuading the executives to let it happen. So that probably is our job, partly, to say that the executive room, however it's laid out, would say, yes, we give you permission to do this in this way. So it's not one thing, but it seems to me that seeking the feedback the way you've just described in New South Wales is exactly where it should start.
Yeah, and that's how we've experienced it. That's how I've experienced it here, Jason, that it just takes time and usually some leadership within an organisation. I mean, I think, you remember Jerry Marr, obviously, he got it going in Southeast Sydney when he was chief exec, passionate about it, and it's still going strong. We had Anne on the panel for Australia speaking passionately about how it diffused, not only through their staff, but through their other hospitals within the district, that they started small and then others could see that the sky wasn't going to fall in, it was okay. And I think you're spot on about the benefits. When people realise the benefits, see the benefits, feel the benefits, then they do engage. I can't believe how quickly time goes when I talk to you guys, and I love to talk much more, but there's lots more questions. I'll just see if time before final question. What are the benefits of the platform? I think we've addressed the benefits of the platform, and Becky did that quite well. But we'll be addressing all the questions to people post event. It's getting on the 5 to 8, I think, where you are in the morning. It's 5 to 5 here. We're heading into happy hour at 5 p.m. I just want to thank both of you. I know you're very busy, both of you, lots happening, but your presence today is enormously valued. Your learnings about being on the journey with Care Opinion for some time. Australia, I think, is a country that is adopting, we're seeing that uptake happening a bit more rapidly now. It's been a slow burn, but we're seeing it now, and I think that's because they can see others doing it. So thank you very much. I wish you well. I can see you here. I've got a jacket on here, you guys, in shirts. It's obviously coming into summer in Britain, so it's probably got bathing sunshine, 20 degrees outside.
You're lucky we got dressed.
I don't get up at this time in the morning for just anybody, Michael Graham.
I know, and I'm forever grateful. If we could share a point, I would share a point, Jason, and I look forward to the day where we can travel, and I know you travel, and James. We nearly had both of you over here last May, so a year ago, and it didn't happen because of COVID, but hopefully you will both come out in the near future. So so thank you again very much, and we'll be in touch. Thank you.
It's been great to join you.
Yeah,
Cheers.
thanks,
Bye.
James. Thanks, Jason. Well,